looking at things like the cerebellum. Now, on the intake forms, I told you there was a section called cerebellum. And some of the things that affect the cerebellum are genetic SCAs, which we can see the person becomes ataxic and they get all the cerebellar signs and symptoms. The cerebellum can go all the way through the vestibular system, all the way to the eyes, all the way down to the limbs, and all the way down to gait. And it's one of the things that takes motor movement and it refines it and makes it more beautiful or more flowing or more, you just don't see imperfections while you're intentionally trying to do something. So your voice is a movement, swallowing is a movement, obviously movement is a movement. So a lot of these people will get dysarthric, or their voice will become kind of dysarthric, all right? Their swallowing may not be great, so they lose peristaltic motion and they get dysphasic, okay? That can happen. When you do reflexes, you may see some, instead of just that initial jerk, you may see some pendulosity. And then on the same side overall, there may be no atrophy, but just a minimal loss of tone on that side. So that's why we feel the muscles that we think are atrophy, because we want to feel and see if there's any atrophy in those regions. Other things that can happen with the cerebellum is the cerebellum calibrates vestibular function. So it can take a vestibular system that's sort of off whack or has been changed because of maybe some calcium carbonate crystals going into the ear. Well, the cerebellum can kind of go in there and recalibrate not only the brain's perception, but calibrate the output of the vestibular nuclei on an ongoing basis. Because the canals are typically not in a perfect orientation. So your brain will become plastically centered around where yours are, and that becomes your norms. If your head ever gets into a position where it's rotated or dystonic or changed or your range of motion is off a little bit, now as you move, there may be a canal that's in a different plane and it's acting as if it was another canal, so the whole system becomes different. Some other things that can happen with the cerebellum is you may get nystagmus. You may get some oscillations where there's no real fast phase, there's just both fast phases where the eyes are looking around and it's not clear slow phase, boom, boom. You may get some vertical nystagmus with cerebellar lesions, or hallmark, you may get in-gaze nystagmus, where when you hold your eyes, it breaks down in different directions. Assuming that's not an Alexander's component on top of a regular nystagmus that's already present spontaneously. So with cerebellum, we can see a load of things in the eyes. We can see different movement patterns that become altered, whereas the eye moves in a certain fashion. You'll see weakness or torsion or a dip. I'm not going to go into that as deep here. I just want to kind of go through basic cerebellar testing. So here you are, and you're like, man, I just want to check and see if this guy's cerebellum is not doing so good. You looked at the assessment form, and a lot of the cerebellar questions were off. And then you've already looked and said, well, does it correlate with thyroid pathology? Because we know that TPO antibodies and thyroid pathology may cross-react, and now you have cerebellar pathology. We've already looked at maybe our blood, and we've looked to see if you have an anemia, because we know that some people with cerebellar problems may also have parietal cell or intrinsic antibodies, which changes your blood chemistry, especially the size or the shape of a red blood cell. So we've kind of gone through this and we're like, man, they say they're having coordination problems, they say they're having dizziness, and we've already gone through and done a good vestibular history on them. So you're convinced that it might be cerebellar. So you go through and you're like, I'm just going to check a few things. So some things that we can do are simple tests like finger to nose. Close your eyes, bring your arm straight out in front of you. Now when they bring their arms straight up, you want to look and say, did their arms drift to one side or the other? Okay, did their arms drift to one side or the other? And a lot of times they'll drift in one direction because their brain doesn't have the perception of where midline is. So bring the arms up. So one of the things I like to do is just say, bring your arm back up to where it is. So now a lot of times they'll rebound check and go higher, then they'll go down, and then they'll come back, and they'll be at a different position. Now that can be cerebellar, it can be brain-based lesions, different things can cause that, but I like to check that. And then I'd just like to say, show me some rapid movements. Now you watch and do what I do. I want you to move as quickly as you can. All your fingers move independently. So you check that. And you want to look at speed. You want to look at fatigue. You want to look for posturing. You want to look for changes. Now what will start happening a lot of times when it breaks down is a couple of fingers will start moving together. Or all the fingers will start moving together. Or they'll be like waving their hand and then there's independence on this side. And the next thing we can do is turn the hands up and down. So hold them out and now turn them up and down. So if you start seeing the person doing something like this, where they're waving at you, or it starts ratcheting around, that might be positive. Now, I'm not going to really go through what the difference right now is between using a proximal limb or bringing it down here and doing this where it's more distal component, but it checks and looks at different parts of the cerebellum, and then it breaks down different aspects of the parietal lobe. So, but the big deal is we just want to say, are you dyspraxic or dysdiadochokinetic? So bring the hands back up. So with cerebellar lesions on the same side, we'll see breakdown in movement. And then finally we can say, just do a finger to nose test. So go ahead and close your eyes. Touch the tip of, and I'll touch the finger. Touch the tip of this finger to the tip of your nose. Back out. Touch the tip of your finger to your nose. So as we're doing this, there's some things that we're looking for here. We're looking for, first of all, do they hit their nose? Do they know where it is? Now that's not all cerebellar. Some of that is parietal. And we're looking for this. So let me do some exaggerated positive findings. If they do it and they go like this, that's not good. Obviously they don't know where their nose is. So there's several things that can create this. Skewed maps, skewed somatotopic maps, skewed parietal situations. If they come up and you see this right here. What did you see right there? Slight tremor with intention. Now the closer I get to my nose, the more complicated the movement becomes, and the more the cerebellum needs to kick in order to have precision. So you see it break down. Here's another thing you may see. What did you see there?
Titubation.
A titubation where the head or the trunk is now going back and forth. So I'll ask them to do that. Now another thing I may do to bring out that tremor, you can't, so you can just watch this rule. So just touch your finger to your nose and hold it there. Now you may see a tremor here in the other fingers, but it's hard to see it on this one because it's anchored down to the nose. Bring it back out. Now just pretend like there's a space that's about an inch in front of your nose and stop right there. A lot of times right there they'll come in and you'll see them going. And that's where you'll see the tremor break down because they don't have it anchored on their face. And then come back out. So there's some simple tests. Rapid movements, coordination, listening to them talk, talking about their swallowing, seeing if things are pendulous, feeling for tone, asking about vestibular symptoms, looking for a loss of smoothness in pursuit, which can also be parietal, but it can also be cerebellar, looking for in-gaze nystagmus, which if they don't have a primary or a secondary nystagmus and then they have in-gaze breakdown, that could be more cerebellar, assuming you don't have a weak muscle pair group, or overactive muscle pair group, making another one seem weak. The other thing that we need to do is start looking at heel to shin, because not only will the upper limb be changed in regards to spinocerebellar feedback and proprioceptive awareness, it'll happen in the arm, but it'll also happen in the lower extremity. So let's have you lay down. And can you get this? So these are your typical heel to shin tests. So if you want to stand up and watch this, that's fine, or gather around. So now a heel to shin test is a little bit trickier than you think. You can't just go do heel to shin, start at your knee. Let's make it a precise test. So if somebody, first of all, bring your heel, stick it on your kneecap. Now, what you want to see somebody do is, you want the knee up like this, because if they do this, they'll slide their heel off, and they'll use their Achilles tendon to just hook over the shin, and then as they go down, anybody can do that. So you want their knee up, bring your foot up, up like this, up. Now put your heel on just your kneecap. Now right here in this position, you can just watch them hold this, and then just say, bring your foot up and tap your kneecap a little bit. Now a lot of times they'll start doing things like this, and they'll miss their own leg. So you can look at that. And then say, just slowly, I want your toe in the air, straight up. Don't let it deviate. I want you to run the very tip of your heel down your shin to the top of your big toe and then tap the end of it slowly. Go. Okay. Very good. Now, what we're looking for is this. Hesitations in movement, sliding off the edges, coming up, missing the foot, and then missing the kneecap. You see how much more precise that is than just saying, hey, just run the foot down the leg. That's a little bit more precise. So when we compare the eyes, and we compare muscle tone, and we compare coordination and speed, and finger to nose, and look for tremor, and we look at our assessment section, and then we do lower extremity, up, and then last but not least, we watch gait. So as we turn, just walk. We obviously want them to have an arm swing. Turn around, come back this way. But the feet should be really about shoulder width apart. They shouldn't be wider than that, so we don't want to see what's called an ataxic or wide base gait. So you compare all those things together, and then you can start to say, man, this not only looks like cerebellum on the intake, this looks like cerebellum on the physical exam. And when you see things like that, I want to know if there's antibodies. I want to be able to examine them and say, does this look like an inherited or genetic-based issue? Look at their feet and make sure they don't have arches and hammer toes and other signs of hereditary pathology, like a Friedreich's ataxia or something. And when you do that, you've got a pretty good examination of your cerebellum, just basic evaluation. So when you see that section show a positive, do a physical examination to see if there's any equivalent changes.